So hi everybody, I'm Nikki Abela, as Grace said. I'm an emergency medicine trainee from Liverpool, and this is Julia. We've made her since we last met. I'm here to speak to you about brachymemendo, which unfortunately isn't a spell to mend broken bones, but actually I'm trying to find a way to tell out NAI from long bone fractures in the very young, particularly humerus and femur fractures. As you probably have realized by now, children get up to all sorts of mischief, and that's why they break their bones quite a lot. But actually, fractures are the second most common manifestation of abuse in children after burns. This is all children, not just the very young. And what I've realized with Julia is that very young are actually quite demanding, and that puts them at quite high risk for abuse. But they are also defenseless and non-verbal. And they really rely on us to be their defense mechanism so that we can tell out when their accident was inflicted. And there was a theory, or a dogma, if you like, that very young children should not be able to mount enough velocity to break their humerus or their femur if you exclude supracondylar fractures or motor vehicle collisions. And I'm a person who likes dogmas, but I also like to look into the evidence, and I want to know if there is any truth behind this. So what I did was I did a systematic review on the evidence on long bone fractures in the very young, so either less than 5 years, but really the evidence is mainly less than 18 months. For femur fractures in the last 15 years and humerus fractures in the last 25 years, I had to kind of extend that because there isn't very much going on. And what I found is that actually the risk is very high. So the positive predictive value, which is the probability that children with this fracture have been abused, for femurs is as high as 59%, and for humeruses it's 49%. If you include children who are less than 18 months, and you exclude motor vehicle collisions or supracondylar fractures. And it's really, really important that we get this absolutely right, because as you probably already know, and as the papers will tell us, if we miss it, then we're going to send that child back to an abusive environment where they are likely to die from it. And if we get it wrong and refer them unnecessarily, then the families themselves will tell you about the turmoil that referral has done to them. And this is a conference about science and story, so I'd like to start with Jack's story. Little Jack came to the emergency department with his dad when he was just 8 months old. Dad tells us that he was in the room, kind of folding some washing with Jack, when Jack was crawling around, and he crawled out of the room. Didn't think much of it, because he had the stairgate closed. But he didn't know that day Jack's older sister, Anna, had left the stairgate open, and he heard Jack tumble down the stairs, and he rushed out to try and stop him, but obviously couldn't, and found him tumbling down the last 2 stairs, and he clearly says that he hit the bottom and his right leg curled underneath him. And he knew immediately that something was wrong with Jack because he was in hysterics. And he pulled down his trousers and he could see a swelling to his right leg. Jack's story is fictitious, I'm afraid, because I do have to get consent about the patients we see, but it's not very different to what we'd probably see every day. Not every day, hopefully not every day, but quite regularly in the emergency department. And you do an X-ray, and needless to say, you find a spiral fracture of his right femur. And there's something in the back of your head, because now I've told you that it kind of should trigger alarm bells, shouldn't it, about NAI, but spiral fractures especially we don't like. And I wanted to know if there was any evidence in this. And what I found is that in the 1980s, there were some studies which proved that there was a relationship between spiral fractures in femurs and abuse. But actually, the more modern studies say that the spiral fracture doesn't have more probability of them being abused. And it's actually it's spiral because of the angle, but they found that even more transverse fractures in some studies are more likely to be due to abuse. And realistically, what you need to be looking at is the fracture pattern and whether this fits the biodynamics that you're told and the biomechanics that you work out from it. And I was sitting at home yesterday thinking, how am I going to demonstrate this for the kinesthetic learners out there? And what better way than a wooden spoon? So if you had to get a wooden spoon and imagine this is the head of the humerus or the femur, and you take Jack's story. So Jack's dad said his femur was caught underneath his body, so it kind of torted underneath, and that itself causes the spiral fracture. So that makes sense, doesn't it? If he had a transverse fracture, if Dad said he caught his leg between the steps, for example, or got caught in the stairwell, you'd have this piece which would be trapped because it doesn't get much movement outside the pelvis, and the bottom bit doesn't get much movement, and it would kind of snap like that, wouldn't it? That would cause a transverse fracture. Buccal fractures, commonly thought to be accidental or compressive axial load, so not much seen in the humerus or the femurs, but you'd kind of have to do that, and it causes a kink in the bone. Classic metaphyseal lesions are thought to be pathognomonic for abuse, and this makes sense when you think about it, because you have to so you have to twist and pull, and I can't think of many ways that you can do that which isn't inflicted, to be honest. So if you see CMLs, then you have to refer to safeguarding, really. And for a CML to be diagnosed, it's usually a radiologist. And they probably will need to do special views for that. So what I would say, and this is what they said in the Radiopedia talk before, is to write down the mechanism of injury, because radiologists themselves are trained, aren't they, to tell out the fracture pattern and whether this fits the mechanism of injury. And if it doesn't, then they could be our safety net for the red flag. And they might want to do other views as well. And then for comminuted fractures, you all know that it has to be high energy impact. So it would be something like a motor vehicle collision. And if you're thinking about supracondylar fractures, it's usually a fall over a hyperextended elbow, generally a fall out of a bunk bed. Thank you. So back to Jack. We know now that his mechanism of injury actually fits the fracture pattern that we've seen, so are we happy that he's in the clear? Probably not, because that's only really part of the puzzle, really, isn't it? We need to exclude other differential diagnoses, so whether this is accidental, really, or it could be something like osteogenesis imperfecta, or if it's a tumor, maybe, that's causing these fractures. It also look for other injuries, or other red flags for abuse. So most people would have on their Clarking pro forma checklist, and I'll show you one that probably you guys have or something similar. And also the child's age and milestones. So what you want to know is if what you've been told actually makes sense for the child. So if Jack was 4 months and Dad said he was crawling out, then we'd be like, oh yeah, you're definitely lying there. Or especially with the lower age, and this is where the evidence is, that the lower the age, the more chance that the abuse has happened, and that's what's causing the fracture. And in some studies, it's disgustingly up to 90% for children less than 12 months. This is a checklist that's similar to one that we've got in Older Hay. So the red flags for an AI, you guys probably all know this, so I'll go through it really quickly. If the story is vague or lacks detail, if it changes by the time they reach the triage nurse and then if there's a delay in seeking medical help, or the history is not compatible with the injury, it's not compatible with their milestones, their previous attendances, history of violence or domestic abuse of the family, and the interaction between the child and the carer is abnormal. So we usually know all that, but actually, if you look at the papers, the evidence is strongest for these. So age less than 12 months, if the child is non-ambulatory, the history is suspicious, or there are additional injuries present. And the way I see going forward from what I could find is it would be really nice if there was more evidence so that we could come up with a risk probability tool. So in adult medicine, if any of you practice, I know there are a few GPs here, we have risk decision tools for chest pain, and it would be really nice if we could have a risk decision tool for fractures and NAI. So you could have something like an app, and you put in the risks. It tells you, like, this risk would increase, and you put it in, so you ask them out, and then it creates the risk for you. And that would be via a Bayesian model, for example. one of the studies by Baldwin in 2011 tried to do this, but retrospectively, and they found that with 3 risk factors, there's a 92% chance of abuse. So the 3 risk factors were, we'll go back, age less than 18 months in that study, suspicious history, or the presence of additional injuries. 2 risk factors, 87%. 1 risk factor, you still have a 1 in 4 chance. And with no risk factors, you still have a 4% chance. So if we're really saying that we don't want to miss even one child who's been abused, then the risk decision tool is only there to help us. And a wise doctor once said and told me that guidelines guide, clinicians decide, so it's up to us really to decide whether we're happy with the child in front of us and the picture and the pattern we see when we put the puzzle together. Thank you. On the last slide, I had the website for RCEMlearning.co.uk, and the blog of the talk I've just given is up on the website if you want to look up the references. In the next 2 weeks, we'll also be releasing a pediatric induction iBook for anyone starting out in pediatric emergency medicine, which I really encourage you to go and have a look at. Some people from Don't Forget the Bubbles have also contributed to that, and I hope you find it helpful. Thank you.
Fantastic. Thank you, Nikki, for sharing about long bone injuries. And I really like the analogy with the wooden spoon. It really makes it easier to understand. Do we have any questions from Twitter?
There's some comments on the Twitterverse. I think there must be some radiologists in the crowd, maybe, about a call to include mechanism of injury on every single request that we send off, because that helps them correlate what they're seeing a little bit better. Questions from Twitter, there weren't too many, but there was a question about whether there's some typical fracture patterns that we maybe get wrong as suspecting non-accidental injury, but
so
not.
Spiral fractures, it is obviously should be up there in your differential, but it's not necessarily pathognomonic for abuse. We tend to think buccal fractures and supracondylar fractures are accidental, but you can cause abuse anyway, really. So you have to piece it together.
And I guess that's where the story and science come together in our everyday practice.
Yeah, absolutely.